Hi, good morning. Welcome to Grand Round. This is the beginning of the academic year, and instead of sleeping in, Dr. Atkinson insisted on coming today to start Grand Round. We were willing to cancel.
You didn't tell me that.
Today's speaker is Dr. Mandy Atkinson from the Department of Hematology Oncology. Dr. Atkinson completed her pediatric residency at Ohio State and went on to St. Jude's Hospital for her fellowship training. She worked for some years in New York prior to joining the Carilion family in 2005 and has been here since then. She serves as the director of the sickle cell unit and principal investigator of the Children's Oncology group. Dr. Atkinson has been very actively involved in the educational needs of at many levels, including writing the clinical guidelines for management of anemia and fever, and has been the recipient of the 2004 Humanism Award from the Pediatric Residency. Please welcome Dr. Atkinson.
Good morning. I still get nervous standing up in front of people, and my mouth always gets dry, so please excuse me. I was thinking on the way in about things that I've forgotten in some slides, so I'll try and add them along the way. And I was also thinking about other cases that I should have presented. So I could probably have, 5 parts to anemia in children. It's certainly the most common diagnosis that we get asked to consult for, and there are numerous different presentations and causes for anemia. I have no disclosures, but we are building an enclosure similar to this enclosure for donkeys that we're getting. We're only getting 3 of the 5. I'm not that crazy. They are my therapy. You pet them. You talk to them. You feed them carrots. They keep away predators. So the objectives of my talk, we're going to identify causes of anemia in children, know how to classify anemias to come up with a differential diagnosis, understand when to transfuse red cells for anemia, know how to treat the most common causes, recognize when a child with anemia is really sick. I want this to be a practical talk, so I didn't get into a lot of pathophysiology. If you guys have questions, feel free to ask, but I really wanted this to be a talk for everyone that would be interesting and not over everyone's head. Obviously, when anemia gets too complicated, you're going to send them to us, right? So this is a blood smear of normal blood. This is what normal red cells are supposed to look like. They've got the central pallor that takes up about 1/3 the diameter of the red cell. The rest of those white cells are all segmented neutrophils, and you can see some platelets scattered amongst the red cells. This is just a close-up view, again, exhibiting the diameter of the central pallor, the platelets, and then there's a lymphocyte in there that gives you a relative size of a red cell is about this, a little bit smaller than the size of the nucleus of a small lymphocyte. So some things that I think about when I'm taking a history on a child with anemia, obviously it's sort of age dependent, and it certainly depends on the chief complaint of what the patient came in with. But I always ask about the duration of symptoms. Is it more chronic versus acute? What is their diet? Obviously that's very important in younger children with anemia. Do they have any associated symptoms such as fatigue, pain, recent illness, any bleeding history? And I have bolded history because if you ask just about bleeding symptoms, oftentimes you're going to get nope. But if you ask about bleeding history, then it can change. So in teenage girls, if you ask about their periods, you may uncover some menorrhagia, whereas if you just ask, do you have any bleeding symptoms, they're going to say no. Same thing with family history. So I always delve into a little bit more detail when I'm asking about bleeding, because that can uncover some things that you wouldn't otherwise uncover. Family history is important, and then are they taking any medications? On physical exam, are they sick or not sick? Are they pale or are they jaundiced? Their vital signs are important. Are they hypotensive? Then you're in trouble, right? Tachycardia is going to be one of the first signs of anemia. Tachypnea, by then you're sort of in trouble. Oxygen saturation. So I didn't show this as a case, but I actually have a little girl that I diagnosed with hemoglobin Hammersmith, which is a very rare, and I need to write it up because it'll be a case report. But she presented, and it took me a while to realize, I kept thinking, there's just something that doesn't look right about her, even though, you know, it was not a physical anomaly issue. And, well, it took us a few times of seeing her before I had the nurses check an oxygen saturation, and her oxygen saturations actually run in the 80s, and she ended up having this hemoglobin Hammersmith, which is a low oxygen affinity. You remember the Bohr effect from medical school and all that? So she easily releases oxygen to her tissues so that her tissues are well perfused, but her oxygen in her blood is low. So she does fine, but she has low SAPs at baseline. So oxygen saturation can help you, especially if you're looking for something weird like hemoglobin Hammersmith. Lymphadenopathy is obviously important to rule out things like leukemia, as well as organomegaly, bruising, bleeding, and then do they have any physical anomalies that would lend itself towards a congenital diagnosis of anemia? So lab evaluation, this is one of those things that I thought, oh, I forgot to put something on this slide that's very important because it's the thing that scares me the most in terms of anemia. Obviously, you're going to get a CBC, you're going to get a retic, right? That gives you a lot of information about whether it's a productive problem or whether it's a destructive problem. Based on the history, you're going to get things like iron studies, a hemoglobinopathy evaluation, or delve into looking for the newborn screen. You're going to get a SED rate. You're going to get coags, perhaps, if you're worried about something like DIC, osmotic fragility, liver chemistries, DEB, which is going to help you diagnose Fanconi's anemia, and we're going to talk about some of these things. And then for some of the congenital anemias now, we're now doing genetic testing. Can anybody think of what I left off this list? Well, good. I'm glad I'm not the only one. This is the one thing that I always tell residents I don't want you to forget. And what? Well, smear is something else I should have put on there. No. A DAT, a Coombs, right? You don't want to miss autoimmune hemolytic anemia. Those kids can get sick very, very quickly. So please get a Coombs, especially if you're worried about a hemolytic process. All right, so we're going to delve into cases here because I feel like that's the best way to teach. So this is an 18-month-old male who presented because the family said he just looked more yellow. And he'd been looking more yellow for the past 2 to 3 weeks. He had a normal appetite and activity, no infections, so otherwise healthy child. His diet consisted mostly of rice, and he drank 15 to 25 ounces per day of milk. On exam, he was well appearing. He had a grade 2 systolic ejection murmur. He had sallow skin, but no scleral icterus. His CBC showed a hemoglobin of 6.5. If I don't give you guys something, that means it was normal. And there are times when I'll ask you, do you want to know anything else, okay? All right, his MCV was low, so 61. And again, I tried to make it, I didn't put reference ranges up here unless you really needed them because I tried to make it obvious as to whether or not it was normal, high, or low. So clearly he was anemic. He had a microcytic anemia, right? His MCV was low. His RDW was very high at 30%, but his reticulocyte count was only 3%, so clearly not appropriate for his degree of anemia, right? So they obtained lab studies on this kid, and his iron was high at 138, his TIBC was low at 200, and his percent saturation was high at 67. Any thoughts on what's going on with this young man? This is what his smear looks like. So clearly this is pointing out some target cells. I will tell you that he also had, and I think I have a picture, no I don't, of anemiacytosis. So whenever you have an increased RDW, that means you have an increased, right, red cell distribution width. So there are a lot of small cells, there are a lot of large cells, there are a lot of cells in between. So there's a great variety in the size of the red cells. That's what an increased RDW means, okay? I couldn't find a slide that I felt like was exemplary of target cells and anemias, so you got target cells. So does anybody know where you see target cells? There's a couple different things. Okay, keep going. So at this point, I kind of like to put it all together, all right? So we have a well-appearing 18-month-old boy with sallow skin but no obvious jaundice. He eats rice and drinks cow's milk mostly, with a microcytic anemia, no evidence of hemolysis, right? His reticulocyte count wasn't high. No evidence of iron deficiency, and an anemias and target cells on his smear. Any ideas on where to go from here? So target cells are classic for thalassemia. You can also see them in liver disease, but thalassemia is always what I think about when I see target cells. So on this young man, we chose to get a hemoglobin electrophoresis, which showed a hemoglobin E of 50%, A2 that was elevated at 5%, and a hemoglobin F of 45%. So this young man had a hemoglobin E beta 0 thalassemia. So just a point about thalassemia, because this is very confusing, and honestly, if I get anywhere deeper than this, I kind of have to look it up myself. I'm not a hematologist, I like to say. I'm more of an oncologist, which is why I like to talk on hematology and learn it. So the fact that he has beta 0 thalassemia stems from the fact that he has no A on his electrophoresis, okay? So if he had some A, this would be hemoglobin E beta plus thalassemia. He has none, so this is the same in children with sickle cell. If they have no A, it's S beta 0 thalassemia. If they have some A, it's beta plus thalassemia. And it makes a big difference clinically, okay? So for this young man, this seems like an esoteric case, but hemoglobin E is actually the most common hemoglobinopathy worldwide, and this type of beta thalassemia is actually really on the rise, and it makes up for about half of the cases of severe beta thalassemia in the world. So I think that we're going to be starting to see more and more of this. It's a beta thalassemia hemoglobinopathy, so they have decreased beta globin production, right, hence the beta thalassemia. They have a variant amino acid structure, and depending on the combination with hemoglobin E, the clinical picture can be all over the place. So in a hemoglobin E trait, where they have one normal hemoglobin and one E, they have a microcytosis but no anemia. Homozygous hemoglobin E, they have a mild anemia with microcytosis. And then hemoglobin E beta thalassemias range from moderate to severe anemia with the need for blood transfusions to something more of just watching and waiting. But again, this is becoming more prevalent. So depending on whether you have that A hemoglobin, it really varies the clinical picture. And there are different varieties of this. If you have alpha thalassemia trait mixed in with it, it can actually do a little bit better. So there are a lot of different combinations you can have with thalassemia, which is part of why it makes it so complicated. Any questions about that case? Dr. Keyes.
I'm just thinking, your first slide, I got it right. Father drinking a ton of milk.
15 to 20 ounces of milk a day.
I thought it said a gallon.
No, Dr. Keyes.
So that was,
I was trying to trick you. All right, so case 2 is an 11-year-old with fatigue. So this young lady had gradual onset of fatigue over the past 6 months. She had no fevers, no bleeding, no bone pain. She was premenarchal, so hadn't started periods yet. She had a normal diet, and she had gradual weight loss over the past year. She was taking no medications. Her family and social histories are significant for her mom having lupus, and her parents are divorcing, so she's had some stress in her life. On physical exam, she was thin with mild pallor. Her CBC showed a hemoglobin of 8.4, MCV of 67, RDW of 18%, and her platelets were 565. Any thoughts on that, or so far? So we got some additional labs, right? A reticulocyte count's always going to help you with anemia. So her retic was low, so it's a productive problem. Her serum iron studies were a little bit mixed. So her iron was low at 16, or borderline low. Her TIBC was elevated at 480, and her ferritin was normal at 50. So to put it all together, she was a thin, premenarchal girl with normal diet, no bleeding history, with a microcytic hypoproductive anemia, with iron deficiency but a normal ferritin. So why is she iron deficient? Any thoughts? Too early in the morning.
Why I was saying chronic disease.
So, thank you, Dr. Dodd. So chronic disease could do it. Why is her ferritin normal? You're not allowed to answer, Dr. Edwards. So we started looking for potential blood loss causes, and her stool occult blood was positive. We started her on iron and sent her to GI, and she was diagnosed with inflammatory bowel disease. So she kind of had a picture of iron deficiency anemia along with some anemia of chronic disease. So remember, you can have more than one cause, especially in these sort of patients who have some chronic blood losses. They lose iron, but they also have some chronic disease and inflammation. So you can certainly see a mixed picture of these two. And we see quite a few young ladies where, you know, you realize that they're iron deficient and they either haven't started their periods yet. I mean, there is a chance that they have just outgrown their stores, but then typically they'll respond to iron, everything normalizes, and there's no more problems. And kids like this, you can put them on iron and never, you know, everything doesn't clearly normalize. And so these are kids that I always send to GI because even if they're asymptomatic, I've had a few who have ended up having chronic or inflammatory bowel disease. Any questions about her? So this is that table that you see that just kind of talks about the differences in iron studies between, or CBC indices in iron with iron deficiency, thalassemia trait, and chronic disease. You see it in any textbook. It's helpful sometimes. It's kind of the basis of the Menser index as well, which we don't really use anymore. All right, so case 3 is a 10-year-old boy who came in for a well child check. He complains of mild fatigue. His physical exam is normal, but when you ask about the family history, they say everybody in the family has low iron. Has anybody heard that before? Dr. Kraft is shaking his head. We hear it a lot, and it can mean different things. So his CBC showed a hemoglobin of 10.2, an MCV of 61, RDW normal at 13. His reticulocyte count was low at 1.9%, and his ferritin was normal. What do you guys think? You're so quiet this morning. He had target cells on his smear. Does that help you? Have we learned something? Thalassemia. So you can also see basophilic stippling with thalassemia, and this is a picture depicting that. So he had a microcytic, hypoproductive anemia, and a healthy 10-year-old boy with family history of low iron, target cells, and basophilic stippling on his smear, and a normal ferritin. So what else can help you in the CBC? I gave you the answer this time. So this is kind of where the Menser index comes in, and I've pointed this out to a lot of residents, but if you look at a CBC, the number right above the hemoglobin is the red cell number. So it's different. If, you know, the hemoglobin is a concentration of the hemoglobin. The red blood cell number is how many there are. So in patients with thalassemia, the problem is not that they don't produce red cells. They produce plenty of red cells, They just don't produce them normally. And so if you look at that red blood cell number and somebody is not on iron and they're not iron deficient, the red cell number in thalassemia is going to be high, whereas in iron deficiency, that number is going to be low. And that's the whole basis for the Menser index. But you can get fooled because if patients are iron deficient, it's not going to be valid. Or if they're on iron, it's not going to be valid. So thalassemia trait is what this young man has, right? You don't expect full-blown thalassemia because he was only mildly anemic. So they're always going to have this problem. It doesn't change or get worse as they get older. It doesn't get better. But they are at risk for iron overload, which is why it's important to make this diagnosis. So the two main reasons for thalassemia trait in terms of sending them to us are for education. They need to have genetic counseling before they plan on having children so that they know what their genetics are. They know exactly what type of thalassemia they have. And then if their partner has any evidence of thalassemia, then they should have counseling in terms of whether or not their children can be born with more severe disease. The other reason is because these children can look like iron deficiency, right? And a lot of times they get sent to us after the pediatricians have checked the hemoglobin at a year of age, and it's low, and so they'll put them on iron, but the hemoglobin doesn't respond. So then they send them to us, and we end up diagnosing thalassemia trait. Children with thalassemia actually absorb iron more efficiently than patients who don't have thalassemia. So they can become iron overloaded very quickly if you put them on extraneous iron. If they're taking normal intake, that doesn't happen. But it can be a big problem. So that's why thalassemia trait is important to diagnose. Dr. Keys.
This case in your first case, I'm confused about one point. So with thalassemia, you have uniform.
Hang on. At least the way I think about it, uniformly small red cells. So your RDW in this case was low. Why was the RDW so high in the first case? That doesn't make sense to me.
Yeah, and so that's a very good question. So hemoglobin E, beta thalassemia, if you look in the literature, because I have the same question, honestly, they get a xerocytosis. It's a combination that kind of didn't make sense to people. And so they started looking more at the pathophysiology of that specific combination. And they've shown that cells can become dehydrated. And so you can get larger cells, bigger cells. The concentration of hemoglobin can be bigger or higher or lower. So it's all about the sodium-potassium ion transport pump, and that's why you get the difference. So typically in thalassemia, your RDW is going to be normal. Yeah, it's specifically that combination. So good question. Okay, so the next thing you want to know about thalassemia trait is what type is it, right? Is it alpha or is it beta versus another? And this is really only important for genetic counseling. You know, typically these patients have what they have, so again, it's not going to change. They're likely, if it's a thalassemia trait, they're always going to be a little bit anemic and they're always going to be a little bit microcytic. So a hemoglobinopathy evaluation has now taken the place of a hemoglobin electrophoresis. So just so you guys know who are trying to find it in EPIC, we used to call it hemoglobin electrophoresis, and now it's a hemoglobinopathy evaluation, which took us a while to figure out. So if you send this and the hemoglobin A2 is elevated, then it's beta thalassemia. If it's not elevated, it's alpha thalassemia. Again, just a caveat, you have to make sure that their iron studies are normal before you know this is valid, okay? Is there anything else that can help you? We just, oh, I know what the answer is. So what if I told you this was alpha thalassemia trait? Can you think of anything that would help you? Dr. Kraft? Yeah, good job, Dr. Temez. So if you have hemoglobin BARTs on your newborn screen, that's an indicator that you've got alpha thalassemia trait. So you're going to have some alpha thalassemia as you grow up. If it's not there, it doesn't mean that it's not alpha thalassemia, but if it's there, you have your answer, okay? We talked about the rest of that. Dr. Temez?
I wonder if I'm missing something here. If you have a high RBC number, is it really a hypoproductive problem?
It's not a hypoproductive problem. They produce them, they produce plenty, they just don't produce them effectively. So it's an abnormal hemoglobin. It's not a number problem. Any questions about that case? Okay, so just a little bit on the alpha thalassemia syndromes. If you have one gene deletion, they're a silent carrier, and you would not know these people have any problem. The only time that this gets diagnosed is if another family member gets diagnosed with a trait or a more serious form of alpha thalassemia, and you then go back and look at the rest of the family, that's when this is picked up, okay? So hematologically, they're normal. If you have a 2-gene deletion, you have thalassemia trait. If you've got a 3-gene deletion, it's hemoglobin H disease. And then 4, typically those babies are not born alive. They have high drops. For Dr. Edwards?
Can I just go back and address Dr. Smith? The answer is a little bit confusing. It's not a production problem of cells, but it is a production problem of globin chains. So that's why you get small red cells. So they produce a normal number of red cells, so the reticulocyte count is going to be normal. But they don't produce enough globin chains of whatever thalassemia they have. So they produce decreased amounts of either beta chains or alpha chains. So that's why the red cells are small. They're just not filled with globin like they should be. And so, but the hemoglobin that they produce as they get older, it's a normal hemoglobin. So strictly, it's not a hemoglobinopathy where they're producing an abnormal hemoglobin. Early on, unless they have, more than a single chain deletion of alpha globin chains, where they're producing like hemoglobin H or those other abnormal tetramers. Does that make sense? Okay.
Sorry.
All right.
Hope they don't show up with iron deficiency.
Yeah. I mean, usually you can, so I will put a plug in. Usually you can diagnose iron deficiency from a history, right? I mean, it's not always, especially in the toddlers. I mean, in teenagers it can be a little bit more difficult, but between the history and a CBC, I mean, oftentimes, that's all you need. So the beta thalassemia syndromes, you have beta thalassemia trait, you have beta thalassemia intermedia, which is those kids kind of sit somewhere in between. They may or may not be transfusion dependent. Typically, they need transfusions every once in a while, but they're not transfusion dependent like people with beta thalassemia major. Okay. Next case is a 15-month-old with vomiting and diarrhea. They've had 3 weeks of diarrhea, and it sounds like quite a lot. They were also vomiting 4 to 10 times a day. They had a weight loss of 2 pounds in a month, so pretty significant for a toddler. No fever, upper respiratory symptoms, no bloody stools, no ill contacts, and they take no medicines. On exam, they were thin, pale, but in no distress. The CBC shows a hemoglobin of 7.5, an MCV of 96, RDW of 19.8, and a reticulocyte count of 0.9%. So this is what the blood smear looked like. And this is pointing out megalocytes and megaovalocytes and some hypersegmentation of the neutrophils. So again, we have a 15-month-old with vomiting and diarrhea, weight loss, and a macrocytic hypoproductive anemia with some large macroovalocytes and hypersegmented neutrophils on the blood smear. Any thoughts? Dr. Bowles, you are so smart. Have you heard this case before? So you realize that you didn't take a very good diet history initially, so you go back And this child had been on breast milk for 6 months and then switched to goat's milk and molasses. The family had a goat farm. They also ate some cereal. So you check folate levels, and just a plug for red blood cell folate is much more sensitive and specific than a regular folate level. So hematologists order red cell folate, and that tends to be a better test. So he was started on folic acid 1 milligram a day, and 4 weeks later, his hemoglobin had come back to normal as well as his MCV. So this is kind of a plug, too, for remembering that children with acute illnesses, you can also pick up chronic anemias, right? So clearly this child, the vomiting and diarrhea, probably had nothing to do with his folic acid deficiency, but that could be the time that you see these patients, right? So they come in for their viral illness and you uncover this anemia that didn't have anything to do with why they came in. Any questions about that case? So the next case is a 6-month-old with jaundice at birth. So six-month-old white female. They came in for a well child check, and the parents report that the child had hyperbilirubinemia that the neonatology team was concerned about because it was early. So it was in 24 hours of birth, but it did improve with phototherapy. On exam, you have an adorable, healthy baby with no distress, clear breast sounds, no murmur, no hepatosplenomegaly, no jaundice, bruises, or petechiae. CBC shows a hemoglobin of 9, an MCV of 88, an RDW of 17.6, and an MCHC of 37. Anything about those numbers? Your reticulocyte count was 6.1%. The mother had a splenectomy as a child. You guys are getting where I'm going with this one, huh? So this slide depicts spherocytes. So if you note the lack of central pallor, if you look at the lymphocyte nucleus, you see that there are cells that are quite a bit smaller than what you would expect. So those, you can see microspherocytes. You did an osmotic fragility, which showed this lovely picture that everybody has on their boards. So they have an increased osmotic fragility. So this is a 6-month-old who came in for a well child check with a history of early onset hyperbilirubinemia with a normocytic destructive anemia, right? The reticulocyte count was increased, and an increased osmotic fragility and maternal history of childhood splenectomy. So what's the diagnosis? Hereditary spherocytosis, right? So when this child was 9, she presented with recurrent right upper quadrant abdominal pain, and an ultrasound showed gallstones. Sent her to surgery, who recommended having her gallbladder out, and the question came up as to whether or not they should do a splenectomy at the same time. Any thoughts on this? So it used to be that everybody with hereditary spherocytosis got a splenectomy at the age of 5. Now, we don't do that so much. So indications for splenectomy, obviously we still try and wait until they're 5 if we can. If they have a large spleen that's interfering with activities, and I will say that spleens in HS are different than big spleens like in mono or viral infections. So the spleens in HS are very firm. They're not at risk for rupturing. So I don't limit these kids in terms of sports. However, sometimes their spleens get so big that they limit themselves because it's uncomfortable, and playing sports just makes them more uncomfortable, but you don't have to limit them. So if they're not growing well, or if they have severe chronic anemia interfering with their quality of life. So these are the indications for splenectomy now. So in this child, we decided not to do a splenectomy. She has otherwise done well. I think Dr. Kraft knows this patient very well. So she just got her gallbladder out. We left her spleen alone. She's very active. She plays soccer. She is not languishing. Now, I will say that I had a kid when I first got out of my fellowship, and honestly, in my fellowship, we were taught you don't take spleens out anymore for this. And so I was kind of came out with that attitude, and I started following this young man who, he was probably 8 or 9 when I started seeing him. And these kids typically we see yearly. You know, we check on their spleens, we check a CBC, we see how they're doing. And he was kind of one of these kids that was just sort of languishing around, and he was always pretty jaundiced, and his hemoglobin ran like 7, 8 range. His reticulocyte count was always compensated. He never had problems with aplasia or anything like that, but he just never wanted to do anything. And so we finally rethought the whole splenectomy, ended up taking his spleen out, and he was a new kid. So I learned my lesson. There are certainly still patients out there who will do much better having their spleens out, but they clearly have indications like this. Are there any questions about that? Dr. Kraft?
What age should you test the baby?
So if they don't have hyperbilirubinemia at birth, which they don't always, then typically it's 6 months before we would do an osmotic fragility. And this family had lots of children, so I got to meet all of them. All right, so this was a very interesting case for me. 2-year-old presented to the PICU with left-sided weakness after complaining of a severe headache. He was previously healthy, and the parents reported that he just was grabbing his head, you know, crying with this severe headache for about half an hour. They gave him some ibuprofen. It got better, but he then developed this trouble with walking and moving his left arm. So on further history, his diet seemed pretty normal. He eats what they eat, drank 3 cups of milk a day, no medications. On exam, he was healthy but pale, active and no distress. He did have a mild left-sided weakness, and his vitals were significant for a heart rate of 100, but otherwise he was okay. He had already had a neurologic workup by the time I got consulted, and his CT, MRI, and EEGs were all normal. This is not him, just so you know. I didn't break HIPAA. But you can see, I mean, sometimes in really fair kids like this, it's hard to decide whether or not they're truly pale, because fair to me is different than pallor. So this slide just reminds me to point out the fact that the best place to look for pallor is, you know, the conjunctiva, inside the mouth, sometimes nail beds, but that can be a little bit tricky. So this kid's hemoglobin ended up being 5.5. His MCV was normal at 83, RDW normal, and his reticulocyte count was low. So it was a hypoproductive anemia. He had a normal blood smear. So previously healthy toddler, acute onset headache, left-sided weakness, found to have a severe normocytic hypoproductive anemia with a normal smear. Any ideas? Dr. Bowles, what do you say? No, good thought. I don't have a case on that. This was difficult for me until I looked something up. So this kid actually ended up having transient erythroblastomia of childhood, and you can have neurologic complications. It's rare, but it happens, and so that really threw everybody off on this case. So it's a diagnosis of exclusion, so you want to make sure that you're not missing anything. But if you've got a normocytic anemia with no other causes, the kid is otherwise healthy, typically, and they're in the right age range, it's going to be TEC. So average hemoglobin on presentation, 5 to 6, usually in toddlers. It can be associated with neurologic complications, and really in these kids, I only transfuse for symptoms. Now, if they get down to the 3, 4 range, normally the parents are getting really nervous, and I'm getting a little bit nervous, and so you end up transfusing, and I think I go through that here. So a week later, this kid ended up being a hemoglobin of 5, reticulocyte count still wasn't responding. 2 weeks later, he dropped down even further. The retic still was low. He became more tired, irritable, complained of his head hurting, so symptomatic from his anemia, so we decided to transfuse. And then 3 weeks later, his hemoglobin was 7.9, so a little bit higher than what you would expect for him to be just transfusion blood, right? And his reticulocyte count had improved to 8.5%. So that's really what you're looking for, what you're waiting for in these patients with TEC. So once your retic starts improving, it's hooray, hallelujah, you can breathe a sigh and know that they're recovering. Very, very rare for this to recur. Any questions about TEC or that case, Dr. Bowles? Honestly, I don't think they know. Yeah. I mean, usually these kids are not hypoxic. So, and you think about all the kids with chronic iron deficiency anemia, and, you know, they're not hypoxic. So, but there's quite a few case reports in the literature, and it's clearly a side effect or a complication that they can get. It did, and it resolved quickly, even before he left the PICU.
Dr. That's what I was going to ask. Stand down.
All right, so next case is a 3-year-old with fevers, and he was refusing to walk. So he came to the Pediatric Hematology Oncology Clinic as a consult for anemia and had a rheumatology consult set up in the next 3 months because at some point along the way, somebody had seen him and decided that he likely had a rheumatologic condition. So on history, he had fevers to 103 off and on for 3 months. He wasn't walking. He actually developed a femur fracture, and then even out of the cast, he was still not walking because he said his legs hurt. On physical exam, he was ill-appearing. He was wasted, but in no acute distress. He was very irritable and remained that way his entire treatment course, I think. He was pale. He had shoddy cervical nodes, hepatosplenomegaly, and he had bruises all over the place. So what does this little boy have? Leukemia. And honestly, this is a kid that the minute I walked into the room, I knew that's what he had. So I think he had progressed from the last time anybody had seen him, but anyway. Don't wait 3 months for a rheumatology consult if there's any chance that the kid can have leukemia, is the lesson here. So his CBC showed a hemoglobin of 7.1 with a normal MCV, RDW normal, but his white count was low at 2.3 and his platelets were low at 24,000. And this is what his smear looked like. So 3-year-old with fever, refusal to walk, lymphadenopathy, hepatosplenomegaly, normocytic anemia with leukopenia and thrombocytopenia, and blasts on the smear. So classic presentation for acute lymphoblastic leukemia. So just to remember that anemia can be a part of leukemia presentation. Typically, you're going to see another cell line problem, but it's important to look at the blood smear, or at least have somebody else look at the blood smear. All right, next case is an 8-year-old with yellow eyes, and I did this case several years ago when I did some anemia cases just because I love this. So if you've already seen it, don't answer. So yellow eyes and fatigue. His yellow eyes have been since yesterday, more tired just today. He has a normal diet. He's on no medications, and he has no history of anemia in himself or in his family. On exam, he had scleral icterus, mild tachycardia with a flow murmur.
I had a question on the last case, whether the fracture should have been a
pathologic fracture?
Yeah.
Yeah, yes is the answer. I think oftentimes you'll see, and this is a kid who came from elsewhere, so I don't even think we reviewed the films, to be honest, because at that point it was obvious what he had, and that whole problem had been dealt with and done. But oftentimes you'll see problems on x-rays with the bone marrow, and that can kind of trigger you. I don't know whether this young man had that or not, but that's a good question. He'd been sick for quite a while. I mean, his spleen and liver were huge, and yeah. Okay. So this young man's CBC showed a hemoglobin of 7.5. His MCV was normal. His RDW was maybe a little bit high. His additional lab showed a reticulocyte count of 10%. So 8-year-old. He was an African-American, healthy boy with acute onset of scleral icterus, mild tachycardia, and normocytic destructive anemia. So just to talk a little bit about the differential diagnosis of red cell destruction, you can have extravascular hemolysis, so things like autoimmune hemolytic anemia, membrane disorders like spherocytosis. You can have enzyme disorders like G6PD deficiency or pyruvate kinase deficiency, which I also follow a young lady for, and the hemoglobinopathies like sickle cell disease. You can also have intravascular hemolysis like hemolytic uremic syndrome and DIC, but typically those kids look sick, right? So you did a Coombs on him, which was negative. You sent an osmotic fragility, which you'll get back in a week, and you sent G6PD and pyruvate kinase levels, which have the same turnaround time. So you go back and you take a little bit more history, and you find out that he was with his grandma over the past weekend, and he was helping her clean out her closets, and in her closet were mothballs. And you look at his blood smear, and you see this. Anybody know what these cells are called?
Bite cells.
Bite cells, good. So what's this diagnosis? G6PD deficiency. Dr. Doherty.
I just want to point out that Pennsylvania NGC screens for G6PD on the newborn screen, and as far as I'm aware, no other states do.
Wow, that would be nice.
Do you want to repeat that for? I couldn't catch.
Yeah. So.
DC and Pennsylvania screen for G6PD, but to my knowledge, no other states do.
And it would definitely be nice to know this when they're newborns, because you can clearly avoid medications that can precipitate hemolysis, and you can warn the families that it may happen when they get sick. So you can also see the hind bodies. Dr. Parmish.
I had a question.
Yes,
I thought there was no camphor in mothballs anymore.
Oh, these were a box of old mothballs. Is that true? I don't know that. I would still, if I heard mothballs, I would still worry about G6PD. All right. So G6PD deficiency, it's the most common red cell enzymopathy. There are different types. African Americans tend to have the most common type, which is a mild self-limited form. And then you hear about Mediterranean G6PD deficiency, and those are the ones that are classic for the favism, where they eat the fava beans and get into trouble. So the oxidative stress leads to intermittent hemolysis. Things that can do that are a whole list of drugs, fava beans, mothballs, and infections, but maybe not mothballs now. All right, any questions about that case? I think this is my last one, so we should be good and have a few minutes for questions. So this is a 6-month-old male who presented for a well child check. They were doing fine. First-time parents said that he sleeps a lot, but otherwise they felt like he was doing well. He took 6 ounces of formula every 4 to 6 hours, and it was Similac with iron. They would put a few spoonfuls of cereal in his bottles because otherwise he just wouldn't sleep very long. On exam, he was well appearing. He did have fair skin. Actually, yeah, never mind. And he had pale mucous membranes. So his CBC showed a hemoglobin of 6.3. His MCV was high at 100. His RDW was normal at 12.5, and it was a production problem. His reticulocyte count was low. So on his smear, he had some enlarged red cells, but that was basically it. We marrowed him, and this is what it showed. So the arrow is actually pointing to a red cell precursor. Do you guys see that yellow arrow there? And there's a paucity, right? If you've got an anemia, typically you're going to want to see a lot of those little guys, and there were very, very few in this child's bone marrow. So he had a lot of other early cells coming out, but not early red cells, so that's a problem. So a 6-month-old healthy pale infant with a macrocytic hypoproductive anemia. So the differential diagnosis for congenital red cell aplasia, this kid's white count and platelets were both normal. Blackfan anemia, which now is pretty much diagnosed genetically with the RPS17 gene. Fanconi anemia, which we're still diagnosing with the DEB, which is a chromosome fragility test. And then dyskeratosis congenita, which I believe we're still diagnosing with telomere lengths, or at least starting with that, and then doing more genetics. There are probably other things that need to be on this list, but they would be quite esoteric. So just a little bit on Blackfan anemia. Oftentimes they're going to just present with pallor. Usually they're going to present before a year of age. The CBC shows a decreased so a macrocytic anemia with a decreased retic, normal platelets, normal white cells. You can send RBC adenine deaminase. If these kids are transfused, that test kind of goes out the door. So again, we typically diagnose this genetically at this point. For the board, they may ask you these things though. So increased ADA, increased fetal hemoglobin, increased EPO levels, which I've actually never sent. And then the bone marrow is going to show a paucity of erythroid precursors. It is associated with physical abnormalities, so growth retardation in some, craniofacial anomalies, upper limb, cardiac anomalies, urogenital anomalies, and it is associated with a low percentage of malignancies. So they have registries for these patients at this point. We're trying to learn more. So myelodysplastic syndrome leading to AML is one of the things that you can see. So you can see in the registry there's 8 out of 420 patients who have been diagnosed with those things, and then osteosarcoma, 3 patients in 420. And I put this picture up here just because not every patient that I've had -1 has looked very similar to this little girl. So oftentimes they're short and they just have a little bit of a funny look to them. And I'm sure Dr. Doherty can point out all of the anomalies that she has. So again, what they don't have, if you look at their blood smear, is, does anybody know what this cell is that's in here? It's called a fried egg. It's a red cell precursor, so a nucleated red cell. And these patients will not have this in their blood. And yeah, there are some. These are probably just artifacts, though. Any questions?
Hang on.
Thanks for that great talk, Mandy. I really enjoyed it. This just reminds me that in getting ready for my board recertification that there's more to anemia than iron deficiency anemia and thalassemia trait. What resource would you recommend for studying for those of us who are not going to rotate on HEMONC with you and need to brush up?
And I can send an email out. There's a great review article on anemia that I can send out and have sent out to everybody that I think would cover everything.
Any other questions in the room? Comments? All right, we've got a couple minutes so I can unmute the phones. We'll see how well that goes. It didn't hang up on us today. That's a plus. All right, if you're on the line and you would like to ask a question, stand by. If you do not want to ask a question or make a comment, please just put your phone on mute now.
The conference is now in talk mode.
Okay, if anyone on the line has a question or would like to make a comment.
Alice, I have a question.
Okay, go ahead.
Hi, it's Kim Dunsmore. Mandy, that was just a really wonderful review of all types of anemia done in a really practical way.
Thank you.
And I did want to point out that it's really important because a lot of times general pediatricians will be seeing iron deficiency anemia. Point out again what you stated, which is iron deficiency is actually just a symptom or a sign, and you have to figure out why they're iron deficient. Iron deficiency anemia is not the final diagnosis. It is very important to figure out the etiology of the iron deficiency.
That's a great point.
Hey, Mandy, it's Amy.
Hi, Amy.
Hi. You know, your case of Blackfan gave me the willies a little bit because as a primary care pediatrician, I probably wouldn't have gotten a CBC on a 6-month-old whose parents just said he slept a lot, especially first-time parents. unless
you
my
would have picked
history
up
said it
pallor
was
on the exam, Amy.
a lot.
You would have picked up the fact that they're pale.
Okay. The other thing, though, is how often, maybe this is to you or Emily, you said they always look a little funny looking that you've seen. How often do they have another dysmorphism that I'm going to see?
I think, yeah. Dr. Doherty,
because, you know, it's a rate of 50%, 40%.
No, Dr. Dunsmore just sent me a diamond Blackfan anemia who looked normal. So I'm sure that these patients, when they don't have dysmorphisms, are extremely under-ascertained. So I'm very concerned about that. But I thought that the little girl that you sent me should get a genetics workup if she walks in any general pediatric office. That would be important. It looked like she had a hand abnormality, although it was hard to see.
Well, remember, too, that if they're not in trouble, then the fact that they're going undiagnosed so far is okay, right? So they're going to call themselves to attention when they need attention, okay? Does that make sense?
Oh, I like that. Thank you.
You're welcome. You're a good pediatrician, Amy.
Okay. Any other questions or comments on the line? Okay.
All right. Thank you, everybody.
Very much.